Hello, everyone. Thank you for joining today's web interface support call for ACOs, groups, and virtual groups. During this session, CMS will highlight important information and updates on reporting quality data through the CMS Web Interface for the 2021 performance period. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone and support call questions box, and CMS subject matter experts will address as many questions as time allows. You are welcome to submit questions during the presentation or wait to submit your questions until the Q&A portion of the call. Now I will turn it over to Sandra Slaughter at CMS to begin.
Thank you, Emily. Welcome, everyone, and thank you for joining us today as groups, virtual groups, and ACOs prepare for the CMS Web Interface Quality Reporting. I'm Sandra Slaughter from CMS, an expert on the CMS Web Interface. Joining me on the call today are other CMS experts. CMS experts and contractors who will share helpful information on the CMS Web Interface Quality Reporting and answer your questions during the question and answer session after today's presentation. Today's call will focus on 2021 quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Today's slide deck, recording, and transcript will be available on the QPP webinar library within the next 2 weeks. Next slide, please. This disclaimer slide is about the presentation. Information in this presentation is current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program or Shared Savings Program ACO regarding updated information. Next slide, please. And now we will review announcements and reminders. Next slide. The CMS Web Interface will close at 8 p.m. Eastern Time on March 31st, 2022. Your submission will automatically be accepted at the submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. Our final support call will be held on Wednesday, March 23rd, 2022 from 1 to 2:30 p.m. Eastern Time. Topics will include frequently asked measure questions, and additional topics may be added prior to the support call. Next slide, please. The CMS Web Interface FAQ document was updated to include the March 31st, 2022 deadline for submitting an extreme and uncontrollable circumstances exception application. Recording, slides, and transcripts from the February 9th CMS Web Interface support call are also available on the QPP resource library. Next slide, please. The CMS Web Interface Application Programming Interface, or API, is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. The information on this slide is a reminder that requesting an other CMS-approved reason should be reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or exceptions in the measure specifications. Submitting your request for an other CMS-approved reason during the last days of the submission period could cause your request to not be processed. Other CMS-approved reason request submitted after Wednesday, March 23rd may cause your request not to be processed prior to the close of submission. Please submit your request as soon as possible. And now Katie Moore will discuss frequently asked measure questions.
Thank you, Sandra. Next slide, please. The first measure that we're going to discuss today is CARE 2 Fall Screening for Future Fall Risk. The intent of this measure is to screen patients 65 years of age and older for future fall risk during the measurement period. As it relates to CARE 2 and the use of telehealth, screening for a future fall risk may be completed during a telehealth encounter. Next slide, please. The first question in regard to CARE 2 is, who can perform the screening for future fall risk? The answer is the measure isn't limited to a particular clinician type. The quality action can be completed by anyone the organization considers qualified. Question 2, is documentation of an inpatient or emergency department fall screening acceptable? The answer is yes. The measure isn't limited to a particular setting. Question 3, is a fall screening performed via telehealth acceptable? Yes, the screening for a future fall risk may be completed during a telehealth encounter. Question 4, if the patient is non-ambulatory anytime during the measurement period, can they be excluded? The answer is no. The patient would only be considered eligible for the denominator exclusion if they were non-ambulatory at the most recent encounter during the measurement period. Next slide, please. Question 5, what clinical documentation should the medical record reflect to meet the intent of the CARE 2 measure? Screening for future fall risk is an assessment of whether an individual has experienced a fall or problems with gait or balance during the measurement period. A specific screening tool isn't required for this measure. However, potential screening tools include the Morse Fall Scale and the Timed Get Up and Go test. The numerator guidance states that documentation of no falls is sufficient. Medical record must include documentation of screening performed. Any history of falls screening during the measurement period is acceptable as meeting the intent of the measure. A gait or balance assessment meets the intent of the measure. If after reviewing the medical record you find supporting documentation that meets the numerator guidance criteria, then it would meet the intent of this measure. Next slide, please. Now we'll move on to MH1, depression remission at 12 months. The intent of this measure is for adolescent patients aged 12 to 18 years and adult patients 18 years of age or older with major depression or dysthymia to reach remission 12 months plus or minus 60 days after an index event. In regard to use of telehealth for MH1, a PHQ-9 or PHQ-9M doesn't require a face-to-face visit. Multiple modes of administration are acceptable. This includes telephone, mail, e-visit, email, patient portal, iPad or tablet, or patient kiosk. Patient remission, a follow-up PHQ-9 or PHQ-9M results less than 5 may be determined during a telehealth encounter. Next slide, please. Now we'll discuss the frequently asked questions. Question 1. A PHQ-9 has been completed for the patient on paper form and scanned into the medical record, but the score wasn't totaled. Is it acceptable to calculate the score during abstraction? The answer is no. If the score isn't totaled in the medical record documentation, you must select no when asked if the patient had one or more PHQ-9 or PHQ-9M administered during the denominator identification period.
Documentation of a follow-up PHQ-9 or PHQ-9M with a score less than 5 is also required to determine if the patient achieved remission for the numerator. Question 2. If the patient answers the first two questions of the PHQ-9 or PHQ-9M not at all, and the rest of the questions are blank, is the depression screening considered numerator compliant? The answer is no. All 9 questions must be answered to have a valid summary score for a PHQ-9 or PHQ-9M. There must be medical record documentation of the calculated score and date completed. Question 3. Since the age range for the 2021 MH1 measure is 12 to 17 years old and 18 years and older, can we use the PHQ-9 for all of our patients? The answer is yes. You may use either the PHQ-9 or PHQ-9M tool to meet the intent of the 2021 MH1 measure. Next slide, please. Question 4. Can the PHQ-9 or PHQ-9M be performed inpatient, or should it be performed during outpatient encounters only? The answer is that the measure specifications don't limit the screening to a specific setting. And question 5. Can you please clarify the timing used to identify denominator exclusions? The answer is that denominator exclusions for the 2021 MH1 measure must occur during the denominator identification period, which is 11/1/2019 to 10/31/2020, or during the measurement assessment period, which is the 14 months, the 12 months plus or minus 60 days that occur after the patient's index date. And the exclusions are that patients with an active diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or pervasive developmental disorder anytime prior to the end of the patient's measure assessment period should be included. And then patients who were a permanent nursing home resident anytime during the denominator identification period or the measure assessment period should be excluded. So just to reiterate, those denominator exclusions would be applicable to the denominator identification period or during the measure assessment period. Next slide, please. Question 6. Can you explain how to determine the index event date? The answer is you verify the patient has an active diagnosis of major depression or dysthymia during the denominator identification period, again, 11/1/2019 to 10/31/2020. And then you look for the date of the first instance of a PHQ-9 or PHQ-9M greater than 9 during the same time period where the diagnosis is also present, which would be the index event date. You can refer to step-by-step submission guidance beginning on page 9 of the 2021 MH1 measure specification, as well as the measure confirmation flow on page 17. Next slide, please. Okay, that brings us to the end of our FAQ, so I will turn it back over to Sandra. Thank you.
Thank you, Katie. These next few slides will outline the available CMS Web Interface resources. Next slide, please. Please note that 2021 resources are available on the Quality Payment Program Resource Library. We encourage reviewing these documents if you have any questions on quality requirements and measures. We'll continue to communicate any future postings and upcoming support calls. Next slide, please. Materials from previous support calls and transition webinars are available on the QPP Resource Library. Additionally, the help and support page on the QPP website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. Finally, this slide contains links to resources available for Shared Savings Program ACOs. We encourage you to review the materials here for more information. Next slide, please. If you need additional assistance, please contact the information listed on this slide. Next slide, please. And now, before we head into the question and answer portion of this call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuseresearch@cms.hhs.gov. And now I will hand things over to Emily Schultz to begin the Q&A session.
Thanks, Sandra. We're now going to start the Q&A portion of the webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously through the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. And we're going to get started with some questions that have already come in through our Q&A box during the presentation. So the first question that came in was regarding Prev 12. And this question asked, on page 10 of the measure specs, it states to utilize the most recent depression screening. However, then when you get to the measure flow mapping on page 15, it does not state the most recent screening. It states during the measurement period. This is a bit confusing and contradicts what is stated on page 10. For other measures where we need to utilize the most recent findings, like DM2 and the HTN measure, the measure specs specifically state the most recent blood pressure, or A1C, and also states that in the measure flow map. Can you clarify exactly which depression screening should be used, the most recent or during the measurement period?
Hi, this is Katie from the PIMS team. So you do need to use the most recent screening during the measurement period. In regard to the measure flow and how that relates to other specifications, you know, there are some variances in how things may look in the measure just because they are, you know, have different measure stewards. But this is something that we can take back as a note for potential improvement in the future to be considered. So we will make sure that we pass that along. But for purposes of reporting for 2021, you do need to use the most recent screen in the medical record. Thank you.
Great, thanks, Katie. Our next question in the Q&A box is about Prev 5, and this question asks, if the patient is unable to lift arms and the mammogram was not completed, can this be used as a denominator exclusion?
Hi, this is Angie from PIMS. No, there is no exclusion that would apply to that patient, but you can submit a request for another CMS approved reason to skip that patient. In this case, if you would like, you will need some medical record documentation that would indicate that that was the reason why the patient did not have a mammogram, and also if the screening was offered to the patient or not. Thank you.
Great, thanks for that response, Angie. Our next question comes from the Q&A box, and this question asks, if a patient receives an FOBT through the mail from Medicare, completes at home, and sends back to get processed at the lab, would this count towards the numerator of the colorectal cancer screening metric?
Hi, it's Angie again. Yes, this would be acceptable for the measure as long as the medical record documentation was all there to support it. Thanks.
Great, thanks so much. And we have another question that's come in through our Q&A box, and this one asks, if there are beneficiaries that are ranked in our sample for MH1 and PREV12, how should they be handled?
Hi, it's Angie again. You would go ahead and report on both of those patients, one measure at a time, and use the medical record documentation for that patient to determine if they meet the criteria for the measure or if they may qualify for a denominator exclusion. So that may happen, and you can just go through it. They may not apply to both measures once you start analyzing the medical record documentation, but you would go ahead and report both of them. Thank you.
Great, thanks, Angie. We have another question from our Q&A box, and this question asks, is death during the measurement year an exclusion for colorectal cancer screening?
Hi, this is Katie from the PIMS team. So it would be, and just to cover this a little bit, this is true for all measures within the CMS Web Interface for patient confirmation. You would select that the patient is not qualified for sample and the date. If the date is unknown, you can enter the last date of the measurement period. But in this instance, for all measures during patient confirmation, they would be not qualified for sample, and the reason being that the patient died during the measurement period. Thank you.
Great, thanks so much for that response. So now I am going to give attendees a moment to answer questions through the phone line. I don't currently see anyone with their hands raised, but I will give you a moment if you would like to ask your question live to raise your hand so that I can call on you. Oh, great, and it looks like a couple of folks did raise their hands. So Prathima Pichera, I'm going to go ahead and unmute your line so that you're able to ask your question.
Hi, can you hear me?
Yes, we can hear you.
Yes, I did submit my question, in the chat, but just to kind of like maybe learn something about PrEP10 tobacco. Should we be considering, if we have multiple screens, should we consider the most recent one, or can we use any during the measurement period?
Hi, this is Jamie from the PIMS team. Thanks for asking your question. I was a little confused, and even the team was discussing the question once you submitted it, and that's why we did indicate to submit it into the service center just to make sure that we get the right response to you, but I'm glad that you're on the line. When we were looking through the guidance, it indicated that it is the most recent screening. So it says to satisfy the intent of the measure, a patient must have at least one tobacco use screening during the 24-month period. And if the patient has multiple tobacco use screenings during the 20-month period, only the most recent screening, which has a documented status of tobacco user or tobacco non-user, will be used to satisfy the measure requirements. It does go on to say in the guidelines that if the tobacco use status of a patient is unknown, the patient does not meet the screening component required to be counted in the numerator and should be considered a measure fail. So I'm, again, with your scenario, just to make sure that we're covering our bases, if you feel like this answer doesn't satisfy your question, by all means, please submit it to the service center.
Yeah, I did submit that question to the service center also, so I'll wait for the response because there is a bit more nuance to that.
Okay, thank you so much.
Okay, thank you.
Great, thank you so much for that question. We're going to move to the next person on the line with their hand raised. So Gina Bodycott, I'm going to go ahead and unmute your line so you can ask your question. And it looks like you are self-muted as well, so you will have to unmute on your end too to be able to speak.
Sorry about that. So I have sent this question into the service center, but I have not gotten a full answer, so I'm hoping that I can today on this call. We have a patient who was, I believe, incorrectly identified as male and was chosen for the PREV5 measure. We have changed the web interface to reflect that the patient is indeed a male. There is no transition issues or anything like that regarding this. We've looked all through the medical record. But I don't know what the service center has told me to make the patient a skip, but I don't know how to do that in the Excel spreadsheet. Can someone assist me with that?
Hi, this is Laura from the CMS Web Interface product team. All you have to do in the web interface, in the UI, go into report dating, go look for that patient. At the top of the page, there should be a button to edit demographics. And when you change the gender, our system automatically calculates that and should mark that patient as skipped for that measure because they are not eligible.
Okay, great. Thank you so much.
Great, thank you for that question. It looks like that is everyone on the line who currently has their hand raised, so we will go back to answering some questions from the Q&A box. And the first question in the Q&A box asks, how much of a date do we need for PREV 6? Is a year enough?
Hi, this is Angie from TIMS. The year is enough. It does say in the medical or in the measure specifications that the documentation in the medical record must include a note indicating the date the colorectal cancer screening was performed and the results or findings, which normal or abnormal is acceptable. So as long as the year is there, the type of test and the results, that would be enough to meet the intent. Thank you.
Great, thank you for that response. Our next question is a clarification question, and this question asks, to clarify the verbal answer on depression screening timing, you stated it needs to be the most recent screening that is within the measurement period and not the most recent screening in general. Is that correct?
Hi, this is Katie from the PIMS team. So yes, it needs to be within the measurement period. And if you refer to page 15 of the PREV 12 measure specification, it goes through the measure flow. So the first step is to determine if the patient was screened for depression using an age-appropriate standardized tool during the measurement period. And then from there, you would need to ensure that it is the most recent depression screening during the measurement period. Thank you.
Thanks for that clarification, Katie. Our next question asks, is another clarification question, and they would like to know whether or not a PHQ-2 can be used as a qualifying screen for PREV 12.
So on page 6 of the PREV 12 measure specification, it does go through, or it does provide a listing of examples of depression screening tools that may be used. And the Prime MD PHQ-2 is listed. And just to note that these are just examples. So a normalized and validated depression screening tool developed for the patient population in which it's being utilized is the definition of that standardized screening tool. Thank you.
Great, thank you for that response. We have another question that's come in through our Q&A box. And this question asks, for depression screening PHQs that are greater than 0, how do we determine if the depression screening was considered positive or negative? Some providers are faxing us PHQ-9s alone, and we can confirm a 0 score is negative, but if it's 1 or greater, we cannot fully confirm if it's negative or positive. And if we do not have a confirmed negative or positive from the clinician, should we answer no, that the patient was not screened for a depression screening?
Hi, this is Katie again. So this is going to be one of those instances where, we aren't able to tell you how to determine whether that screening is negative or positive. So that's really going to be up to your organization and the medical record documentation that you have on hand. If you're not able to determine the outcome of that depression screening, you may need to report that it was not completed. And it's kind of hard, I guess, to provide guidance without getting more specific. But I guess it is going to be up to your organization and your processes and how, using the guidance within those screening tools to make that determination. So if you would like to submit a ticket to qcp@cms.hhs.gov, we can maybe take a look at that a little deeper. Thank you.
Great, thanks, Katie. Our next question that's come in from the Q&A box asks, for colonoscopies specifically, if a provider documents when it should be repeated, can we count that as the result, i.e. colonoscopy done on X date, repeat in 10 years?
Hi, this is Angie. You need to have documentation of the date the colonoscopy was done, but also if the results were abnormal or some type of results for it need to be documented as well. The repeat in 10 years is really just extra information. So you're always going to need the date, the year at the very least, and the type of test and the result or finding. Thank you.
Great, thank you so much. We've had a request to go back to slide 10, so I'm going to go ahead and go back there so everyone can see that information. So I will hold the slide here for folks who wanted to see that slide one more time. Okay, and now I will see if we can go back to the phone line and see if anyone would like to ask a question live. So I don't see any hands raised right now, but I'll give folks a second to raise their hand if there's anything that they would like to ask live. Okay, and it doesn't look like there are any hands raised, so we will go back to questions that have been added through the Q&A box, but please definitely raise your hand if there's anything you would like to ask on the phone line. The next question that has come in through our Q&A box has asked, if we are unable to receive all of the documentation for someone in the depression remission measure, would we mark them as not confirmed diagnosis?
Hi, this is Katie from the PIMS team. So in terms of MH1, you would need to be able to confirm that the patient had the diagnosis of major depression or dysthymia, and that initial PHQ-9 or PHQ-9M score of greater than 9 during the index event. So if your documentation doesn't support that they had a proper diagnosis during that denominator identification period, or that they didn't have a depression screening PHQ-9 or PHQ-9M during the measurement, the denominator identification period, then you would not confirm them in the denominator. So you would need documentation that they had the appropriate diagnosis and that they had the PHQ-9 or PHQ-9M during that denominator identification period. Thank you.
Great, thanks so much for that response. We've got some more questions that have come in through our Q&A box. So the next question asks about the PREV-6 measure. If the provider mentioned that a colonoscopy was completed on a certain date, but no screen document was attached, will that be counted as measurement met?
Hi, this is Angie. So patient-reported screenings are acceptable as long as there is the type of test and the date, and then the results, whether they were normal or abnormal, or a copy of the results, perhaps. You're not required to have the actual results of the screening necessarily. So if the physician documents that the patient had the test, the date, and the results, that would meet the intent. Thanks.
Great, thanks, Angie. So our next question comes from the Q&A box as well. And that question asks, does E78.0 or E78.1 suffice for risk category 2 for PREV-13, or do we also need to see the language of pure or familiar hypercholesteremia?
Hi, this is Katie again. So just a reminder that coding alone is not considered sufficient documentation when reporting through the CMS Web Interface. Your medical record documentation needs to support the information you report. So in this instance, you would need supporting documentation to show an active diagnosis of familial or pure hypercholesterolemia. Thank you.
Great, thanks, Katie. Our next question from the Q&A box asks, we have a question on the PREV-10 tobacco screening. If in medical records we see in the assessment and plan, tobacco user, occasional cigar use, working on cessation, may we classify that as a cessation intervention as the provider has received indication from the member that they are working on cessation?
I am so sorry. I'm going to answer that question now. So thanks for this question. In regards to the tobacco cessation intervention, I can't really speak to the nature of the documentation itself and whether or not that qualifies or quantifies for a specific numerator option, but I can provide the intent of the measure. And tobacco cessation intervention is defined as including brief counseling, 3 minutes or less, and/or pharmacotherapy. Therefore, if you believe the medical record supports the intent behind what is needed for meeting performance on tobacco cessation intervention, it would be appropriate. Thanks.
Great, thank you for that response. And we've had a request in the Q&A box to go back to slides 16 and 17, so I'm going to navigate there now so folks can see that information one more time. So this is slide 16, and I'll hold here for a moment before going to slide 17. Okay, and this is slide 17, so please do follow up in the chat if these were not the correct slides, and I'm happy to reshare any of the information from the presentation. We're now going to see if there's anyone who would like to ask a question live. So please, again, make sure to raise your hand if you would like me to call on you to ask your question live. I don't currently see any hands up, so I'm going to give folks just a minute to raise their hands if they would like to ask a question. Okay, and while folks are raising their hands, I did see another request to go back to slides 8 and 9 as well. So I will navigate there now. And this is just a reminder that this slide deck will be posted on the QPP webinar library within the next 2 weeks. So you will have access to these slides after the completion of this webinar. But I will hold here for just a moment. Okay, and then I will go to slide 9 as well. And hold here for just a moment. So again, please let me know if you would like to see any other slides again, but the slide deck will be available after the end of this presentation. And it looks like we do have some folks on the line with their hands raised to ask a question. So I'm now going to unmute your line so that you can speak. So Amina Simmons, I'm going to go ahead and unmute you now.
Yes, hello, good morning. Can you guys hear me okay?
Yep, we can hear you.
Awesome. I really needed to know what site or what link can I go to find this recording, and also the specifications for next year, the measure specs for next year. That's the question that I had.
So the 2022 specifications is what you're asking about?
Yes, yeah. Where can what link? I was surfing around the QPPI website and I could not find it anywhere. I didn't know if you guys had a specific link or a specific website I can go and access that from.
Sure. So all of the program resources for all of the reporting years are on the QPP website. So it's qpp.cms.gov. And then if you navigate to the resources dropdown and then select resource library, this page will take you to the full resource library. And then from there you can filter on performance year. And then if you type in the search bar like web interface or specification, something along those lines, it will pull up the measure specs. So this is how you would find 2021 or 2022 and any future or past program years. So it's all on that same resource library. It's just a matter of, I guess, filtering down and searching for the document.
Awesome. Thank you. I probably just need to search a little harder, but thank you guys so much.
Yeah, there's a lot out there. No problem.
Hey, Katie, I did drop a link into the chat if folks want to check out that resource. Thanks.
Thank you.
Great. Thank you so much for that response and for sending that link. We're now going to go back to our Q&A box to answer a couple of questions that have come in that way. So our first question is to verify a patient-reported depression screening is acceptable for PREV 12.
This is Katie again. This question is a little unclear, but just to, I guess, sort of reiterate what's necessary per the measure specifications. So the patient would need to have that depression screen. It can be, they can be screened for depression on the date of an encounter or 14 days prior to the date of encounter. But you would need documentation that the screening was performed and the outcome, whether it was considered negative or positive. And then subsequently, if it was positive, you would need to have documentation of that follow-up plan in the medical record. Thank you.
Great. Thanks for that clarification. So our next question comes from the Q&A box as well. And this question asks, For Care 2, it is my understanding that a fall assessment must be documented in a discrete flowchart field, within a questionnaire, or within a SmartSet tool. Can information regarding falls be obtained from free text provider documentation?
This is Deb from the PIMS team. The Care 2 measure does not require a specific screening tool be used. So as long as your medical record documentation supports that a falls screening has occurred, then you will, meet the measure. You don't have to find that information in a specific location. Again, as long as you have that somewhere within your medical record. Thank you.
Great, thank you for that clarification. So our next question also comes from the Q&A box, and this question asks, if a patient has enrolled in palliative services with the code Z51.5 and the documentation discusses pain medication education, can that qualify the patient to be removed from the sampling under the hospice patients receiving palliative goals?
Hi, this is Katie again. Oh, go ahead, Ange.
Katie, I thought I had marked that one. Sorry. I was just going to say that yes, if you have documentation that there's an encounter for palliative care anytime during the measurement period, then that patient would not be confirmed. Katie, correct me if I'm wrong. Do you have more to say?
Nope, I don't have anything else.
Great, thank you both for that response. So our next question asks, can you clarify again if E78.0 diagnosis code would be accepted for PREV 13, as the diagnosis code is pretty clear that it means pure hypercholesteremia?
Hi, this is Katie. So you are correct regarding the code. However, the guidance for the CMS Web Interface is that your medical record documentation should support the information reported. Coding alone isn't considered sufficient documentation. So your medical record should reflect that appropriate diagnosis, not just the coding. Thank you.
Great, thanks so much. So I'm now going to give attendees just one more opportunity to raise their hand if there is anything they would like to ask live on the phone line. I don't see any hands raised right now, but we will give you a minute to raise your hand if you would like to ask a question. And it looks like we do have one attendee with a question. So Jen Barzak, I'm going to go ahead and unmute your line so you're able to ask your question.
Hi, can you hear me?
Yep, we can hear you.
Hi, I just wanted to clarify again, sorry, on PREV 13. So if it's documented in the chart that it's pure hypercholesteremia, but the code doesn't match that, like it's an E78.5, is that acceptable or no?
So your documentation just needs to support that they had the proper diagnosis to be confirmed in the measure. I guess how specifically that's reflected in your medical record documentation is kind of up to your organization, but you just need to be able to support that the patient had the proper diagnosis to be included in the measure.
Okay, because sometimes we have been seeing it that the coding isn't necessarily specific. The language might be, or vice versa, that the code is specific to what the specs are wanting. So we're just a little bit confused as if we should be going off the language or the coding or just do the combined.
Sure. So just to reiterate again, so coding alone wouldn't be considered sufficient documentation. So if it's language within your medical record that supports it, or a combination of coding in the language within your medical record, that would be sufficient to support it. It's just I think folks that are asking about coding alone, that would not be considered sufficient.
Okay, thank you.
Great, thank you for that question. I'm now going to move on to the next attendee that has their hand raised. So Kieran Herman, I'm going to go ahead and unmute your line so you're able to ask your question. And it looks like you are self-muted as well, so you'll have to unmute your own line as well to be able to ask your question.
Okay, I think I should be unmuted now. So sorry, just to add on to the questions about the coding versus the documentation. So in one of the measures, there's a frailty exclusion, and it specifically says there has to be a claim or encounter, frailty claim or encounter, plus a dispensed medication for dementia. And we had a case where we could see the documentation supported one of the frailty symptoms and a medication for dementia, but we went to the coding document that is provided within the specs in the Excel spreadsheet, and the specific diagnosis code that is on that spreadsheet, that we would think if it's specifically saying it needs to be a claim or encounter, we would think that it would need to be billed. But we couldn't find that, so we didn't exclude it. But are you saying that that's not what the specifications are saying? And this was for Prep 5.
Hi, this is Angie. So for the frailty exclusions, you do want to look at the codes on the coding document that define that for the measure. And if you have medical record documentation that the patient had an encounter for one of those things, I believe it reads claim/encounter, so either would be okay. You don't necessarily need to have it billed, but if you have documentation that in the medical record itself that shows the encounter and all of that, then you can use that. Again, then coding alone isn't acceptable. There should always be some type of documentation in the medical record other than claims that would support what you reported. Does that make sense?
Yeah, so the situation that we had was the patient was diagnosed with multiple sclerosis, and there were frailty symptoms that are listed in that Excel spreadsheet, but we didn't have a specific diagnosis. The diagnosis that was billed for that encounter or assigned to that encounter was multiple sclerosis. And we could see there were SNOMED codes that listed multiple sclerosis, but we don't have SNOMED codes in Epic. So should we have drawn the conclusion that would be excluded because we could see there was diagnosis of multiple sclerosis, unstable gait, and a dementia medication that was dispensed, regardless of what was assigned as a diagnosis or billed?
Yes, you can always use your medical record documentation, and it doesn't necessarily have to be a code. So if there are physician's notes or what have you written in the medical record that match up to a condition listed for frailty, whether it's under SNOMED code or what code, then you can use that.
Okay, thank you.
Mm-hmm. Thanks. You're welcome.
Thank you for that question. We have another participant with their hand raised, so we will next go to Markia Mohair. I'm going to go ahead and unmute your line so you're able to ask your question. And it looks like you are self-muted, so you will have to unmute yourself on your end as well to be able to ask your question. And so we may be experiencing some technical issues with that participant, so we'll give them just a moment. And in the meantime, if anyone else would like to ask a question via the phone line, please go ahead and raise your hand now. We are approaching the end of this webinar, but we do want to give everyone a chance to ask any questions before we sign off. So we will hold here for just a moment for any last questions. And I do see that we've received one more question through our Q&A box that we can address. And this question asks if we anticipate that the web interface will have a similar format next year.
Hi, this is Laura from the product team. Yes, for performance year 2022 submission, the web interface will have a same format.
And this is Katie from the PIMS team, and just to sort of build off of that, the measure specifications were updated for the 2022 performance period. So we know we're in the midst of 2021 submission. However, you know, it would be good to take a look at the 2022 measure specifications and the release notes and updated coding document to see what changes were applied to 2022. So although the format will be similar, we just would like to note that the measure specifications have been updated. Thank you.
Great, thank you so much for that response. And we will give folks just another couple of minutes to submit any more questions that they have before the end of this webinar. So we'll hold here for just a minute for any more questions that come in through the Q&A box, or if anyone would like to raise their hand and ask their question live. Well, thanks everyone for all of your questions this afternoon. This does conclude the Q&A portion of our webinar, so I'll turn it over to Sandra Slaughter to conclude our call.
Thanks, Emily, and thank you to everyone for joining us today. As a reminder, the slide deck recording and our transcript from today's call will be available in the Quality Payment Program Resource Library in the next 2 weeks. Our next support call is scheduled for Wednesday, March 23rd from 1 p.m. until 2:30 p.m. Eastern Time. We hope you'll join us. Thank you.